Before starting my central line insertion, I'm going to verify my patient's labs, looking at their PT, INR, and their platelets. I'm also going to review my patient's allergies and make sure that my consent is signed. I'm also going to make sure my patient does not have any contraindications to the central line being performed, which would be an infection at the site, coagulopathies, or a thrombus or clot in the vein that the central line is going to be placed in. I will then place my patient on an EKG and an SpO2 with an audible tone, and I'm going to go ahead and wash my hands and position my patient in a Trendelenburg position at a 10 to 15 degree angle and have them turn their head to the left for this right IJ insertion. I'm going to also go ahead and manually palpate the sternal and the clavicular head of my sternocleidomastoid muscle to find where my internal jugular vein will lie, which will be in between them. I will then go ahead and don my eye mask, my mask, and my bouffant, and then my sterile gown sterilely, and now I will don my gloves using the closed method. I don't have a lot of room to work with, so my gloves would ideally be on a tray next to me, but I don't have enough room, so I'm just putting them down here. The closed method, I just want to make sure that my hands stay in my gown. To maintain sterility. At this point, I would open up my sterile kit. I do not have enough room, so this is not ideal, but I want to first open away from me and then toward me. At this point, I would have my sterile drape, but it was not folded correctly, and I could not get it to fit back in the kit, so I went ahead and placed it beforehand. But ideally, I'd place my sterile drape on top of my patient. And then I would ask my assistant to place my ultrasound probe in my sterile covering. And I would also put some jelly in there. And then they would pull the end so that the wire will be covered, and that I would put a rubber band around the top to maintain sterility and lay it across my patient. At this point, I'm going to go ahead and assemble my kit. I'm going to make sure that my central line, that my proximal port is clamped and that I have a cap on it, and that my distal port is unclamped and there's no cap on it. I'm going to make sure my guide wire is hubbed and ready for insertion. And I'm going to have my dilator where I can reach it easily, and I'm going to place my needle, my finder's needle, on my syringe and have that where I can access it easily. The patient's skin has already been prepped with chlorhexidine prior to the drape, and I'm going to go ahead and get my ultrasound probe and place it in my non-dominant hand and identify where my internal jugular vein is. This drape keeps slipping because it's on a pillow, so I'm going to have to move it so you can see it better. So in my non-dominant hand, I have my ultrasound, and in my dominant hand, I have my needle and syringe. I want to make sure that I can identify my internal jugular vein, which is easily collapsible and non-pulsatile. If I have trouble identifying it, I can have the patient hold their breath and perform a Valsalva maneuver, which will help increase the size of that internal jugular vein. Okay. The probe is in my non-dominant hand, and using my dominant hand, I'm going to insert my needle, making sure that my internal jugular vein is in the middle of the screen at a 45-degree angle. My computer is about to turn off, so I have to tap it. Sorry. So non-dominant hand at a 45-degree angle, aiming at the ipsilateral nipple. And once my needle inserts my skin, I'm then going to walk my hands back so I can begin to aspirate as I inject, using that negative pressure technique. As I inject, I'm looking for venous blood, and I'm looking for tenting on my ultrasound. Once my needle is in my internal jugular vein, I'm then going to place the probe down and take my needle and secure it and remove my syringe. I know that it is in the internal jugular vein because there will not be pulsatile arterial blood. It should be venous, non-pulsatile blood. And if I have any concerns, I can place this tubing on my needle to ensure that there is no, and transduce it to ensure that there is no pulsatility. I remove my syringe, and then I'm going to take my guide wire and place it at the hub and advance it into my needle 10 to 15 centimeters. As I'm advancing, I'm listening for any sort of arrhythmias, and I'm watching for any PVCs or arrhythmias. If I have VTAC or student run VTAC, I can remove the guide wire some and then re-advance until there is no ectopy. Since I'm on a pillow, it will not advance to 10 to 15 centimeters, which is going to be starting at the 2 black lines on my guide wire, but ideally it would be there. Once I am at 10 to 15 centimeters, I'm going to go ahead and remove this, making sure to maintain sterile technique while doing so. And I'm going to go ahead and take my ultrasound with my non-dominant hand and confirm guide wire placement into my IJ, and make sure I take a picture and put this into the chart. Once my ultrasound placement is confirmed of my guide wire, I'm going to then remove my needle, making sure that I maintain control of my guide wire the whole time and being careful about my sterility. Next, I could, if I had a scalpel, I could make a small incision at the skin to make room for my dilator, but I don't have that. So we're going to go ahead and try to advance my dilator. Keeping my hands on the guide wire at all times. Since this is a pillow, my dilator will not advance, but I want to advance it 2 to 3 centimeters. Once it's advanced, I can then remove my dilator and take my catheter and thread for insertion. Once my guide wire is coming out of my catheter, I'm going to advance with the push and pull technique. Once again, since it's the pillow, it will not advance, but ideally, we want my catheter to be 12 to 17 centimeters, and the skin, which should be indicated by the 2 black lines, is my 10 centimeter marking. And these are 1 centimeter markings all the way up until I get to 15. Once my central line is advanced, I will then go ahead and remove my guide wire, which will be difficult since it's not actually in the pillow. And I will then, if this was actually in the skin, this like this. I'm going to aspirate and flush saline out of all ports to ensure I have correct placement. Aspirate, flush saline, and lock. And recap all my ports. I will then get a chest x-ray. Sorry, my computer is going to. I will then get a chest x-ray to confirm placement and ensure that there is no pneumothorax and that it is in the correct place. That is it.